Hello students, I am Dr. Madhu Choudhary, your pathology faculty at DigiNerve. Let's have a quick recall of all the pathology MCQs asked in your recent INI-CET exam, that is the November 2025. Okay, if you see, there were around 21 MCQs that were asked in pathology. I'm telling you a tentative number, could be an overlap in physiology as well as medicine or any other subjects also. So there were 21 MCQs, out of which 5 were asked from general pathology, 5 were asked from hemat. Surprisingly, this time hemat had a very less share of questions. Only 5 questions were asked from hemat. That is not usually seen in your INI-CET exam. But there were 11 MCQs in your systemic pathology. So 5 from general, 5 from hemat, and around 11 from systemic pathology. If you see the quality of the questions or the difficulty level, I think the paper was not that difficult. It was moderate to easy, you can say. And that is the trend that we see. November ke exam INI set ka is always relatively easier than your May exam. So let's try to discuss what all questions were asked. Please note that this is just a recall session. So we might not have complete questions, but we do have a basic gist of questions. And I would request all of you कि अगर आपको कुछ और inputs आते हैं question में, so please let us know, right? So let's begin with the first question. Where is onion skin fibrosis seen? See, this paper, there were a lot of one-liners, but the importance was on the PYTs. If you had done your PYTs thoroughly, I'm sure you would have been able to crack majority of patho questions at least. So the focus was on PYTs. Of course, there were a couple of PYQs also and many one-liners. So it was a moderately easy paper, I would say, right? So onion skin fibrosis seen in? Straightforward question. We all know onion skin fibrosis is seen in your PSC. That is your primary sclerosing cholangitis, right? Primary biliary cholangitis में क्या होता है? You see florid duct lesion with granulomatous destruction. Biliary atresia में you will see fibrosis and obliteration, of course. Acute cholecystitis, as the name suggests, you will see inflammatory cells. So the correct option here is primary sclerosing cholangitis, right? Let's move on to the next question. Now, this was a little tricky question. I would not say difficult, tricky and time consuming. You had to identify with the stain, with the element that is stained and the color of the stain. Okay, so let's see every option. Pearl stain. Pearl stain is used for iron. Yes. But do we get a red stain, red color on it? No. What do you see? You see blue color. As the name suggests, Persian blue, pearl stain, you would have to see blue color. So it is an incorrect option. Alizarin again, the dye's name is alizarin red, which stains calcium. So you will see a red color and not black. Van Giesens, again, it stains elastin, but do you see blue color? No, you will see black color. So the only option left that should be correct and is correct is Giemsa stain. Giemsa stain, you stain it for mast cell and you see purple color. So this is the correct option. Giemsa stain ke andar, what is the Giemsa stain? It is a type of metachromatic dye. Metachromasia means the dye is of some color and you will see a different color. So it is Giemsa stain. It should be only 4, right? Okay, now let's move on to the next question. A female carries an autosomal recessive mitochondrial disorder. Which of the following system are most likely to be affected? Now, it's a female carrier, autosomal recessive mitochondrial disorder. A little tricky question. Again, mitochondrial disorder. Mitochondria, where do you find large number of mitochondria? Of course, we see large number of mitochondria in cardiac and skeletal muscle and also in ocular muscles. So the correct answer is cardiac and skeletal, right? Let's move on to the next question. Now, identify the major and minor criteria of Jones rheumatic fever. Right. Jones criteria for rheumatic fever. What are the major and minor criteria? I'm not sure if this question has been framed, if this question was asked in this manner only. But if you see shortened PR interval, is it there in the Jones criteria? No, it is prolonged PR interval. Erythema margin nodosum, again, not a criteria, neither a major criteria nor a minor criteria. But yes, definitely polyarthralgia, carditis, and chorea are there in the minor and major criteria. So the correct answer is D, right? Moving on to the next question. Now, what are the correct options regarding Peutz-Jeghers syndrome? Peutz-Jeghers syndrome is a very favorite topic for your INI-CET examiner. एक question इसमें किसी ना किसी form में तो आता ही है, right? So, let's rule out the option. Let's see which all options are correct. STK11 mutation. Yes, we do see STK11 mutation in Peutz-Jeghers syndrome. Does it show arborizing pattern? What do they mean by arborizing pattern? The Christmas tree appearance, and we do see it in PJ syndrome, right? So this is also correct. This is also correct. And autosomal dominant, again, this is also correct. Congenital hypertrophy of retinal pigment epithelium. Do you see it in Peutz-Jeghers syndrome? No. Where do you see it? We see it in familial adenomatosis polyposis, right? This is not there in Peutz-Jeghers syndrome. So the correct options are 1, 2, and 3, right? Let's move on to the next question. What is the molecular explanation for the worsening of neurological symptoms when megaloblastic anemia is treated with folic acid? Okay, there is megaloblastic anemia and you are treating with only folic acid. What could be the cause for worsening of the symptoms? We have already studied in our lecture. It is folate trapping due to methyl THFA, right? So this is the correct option. All right. Okay, now, which of the following findings are associated with mantle cell lymphoma? So, this paper, lymphoma pe bhi question tha, anemia pe bhi question tha. Surprisingly, there were no questions on leukemia. So, now they've asked you about mantle cell lymphoma. What have we studied in mantle cell lymphoma? I've told you a number of times. Remember that story? Boys go mental and go for cycling. Please, no offense to boys, but boys go mental and go for cycling. So your cyclin D1 has to be positive in mantle cell lymphoma. SOX11, again, we've studied, that was the new marker, right? I've already told you in my earlier classes, SOX11 was positive, a new marker positive in mantle cell lymphoma. So cyclin D1, SOX11 positive. CD10, is it positive? CD10 kiska marker tha? CD10 was seen in your follicular lymphoma. And CD23 was positive in CLL. So mantle cell lymphoma, 1 and 2, that is your cyclin D1 and SOX11 positive. This is the correct answer, right? Let's move on to the next question. A 22-year-old athlete collapses and dies suddenly during the game. Autopsy reveals ventricular hypertrophy. What is the underlying cause? See, this was a direct PYQ. They've already asked you in a previous INI-CET exam. Same question was asked. A young athlete died during the game, football game, and what could be the reason behind it? Autopsy revealed ventricular hypertrophy. But if you see it in this picture, what do you see here? You see asymmetrical septal hypertrophy. Okay, asymmetric septal hypertrophy. So what is your diagnosis here? What is your answer here basically? HOCM needs to be identified, need to be screened in case of family history, right? Hypertrophic cardiomyopathy needs to be evaluated in the family. Let's rule out the other options. Died of valvular disease? No, there was a sudden death without any predisposing factor, right? Then image shows feature of chronic heart failure, unlikely. Coronary artery disease due to increased cholesterol, again, no. So family history of HOCM needs to be screened. That is the correct option here, right? Let's move on to the next question. Now, a patient's blood report shows MCVs of 76 femtoliter. He visits the OPD. Which of the following condition is most likely to be responsible for this result? See, I'm not sure if this question has been asked in this manner only, because this is a very easy question, cannot be expected an INI set in a straightforward format. Okay, just say they are just telling you MCV come hai, what are the causes? We've already studied what are the causes of MCV, low MCV or microcytic hypochromic anemia. What mnemonic have we studied? We have studied about SITA. SITA is your sideroblastic anemia, iron deficiency anemia, thalassemia, and anemia of chronic disease, right? Or if you can say Setal, L is your lead poisoning. So these are your main causes for microcytic hypochromic anemia. So it can be iron deficiency anemia, B12, no, B12 में क्या आता है? We see macrocytic or megaloblastic anemia. Again, thalassemia हो सकता है, lead poisoning हो सकता है. So the correct option is A, C, and D here. D option, right? A, C, and D, it could be iron deficiency, thalassemia, lead poisoning, Sita mnemonic. We've studied it multiple number of times, right? Okay, let's move on to the next question. A patient presents with microcytic anemia, elevated RBC, and a Menser index of less than 30. What is the next appropriate investigation? Okay, this is the second question on your anemias, that to microcytic anemia. But here they've not asked the causes. They've asked us to tell us what is the next appropriate investigation in a patient with elevated RBC, microcytic anemia, elevated RBC, Menser index of less than 13. Before we move ahead, let me tell you what is Menser index. Menser index is your MCV upon RBC count. And what are the two conditions in which we check for Menser index? That is your iron deficiency anemia and thalassemia trait. दोनों में MCV लो होगा, but RBC index in iron deficiency anemia क्या होगा? It could be normal or slightly decreased. But thalassemia trait, the RBC count would be raised. So Menser index being MCV upon RBC, what value do we see in iron deficiency anemia? Since the RBC count is low, MCV is also low, so it will be more than 13. But thalassemia trait may it will be less than 13. And what is the confirmatory test for it? It is HbA2. HbA2 would be normal in what case? It would be normal in iron deficiency anemia, and it would be more than 3.5 gram per deciliter in your thalassemia trait. That is the confirmation test. Okay, now coming back to the question again, Menser index is less than 13. So this is definitely a case of your beta thal minor. Okay, beta thal minor ke liye what would be the next appropriate investigation? It would be definitely hemoglobin electrophoresis or HPLC, जो भी option होगा, right? Right? So this is the answer. Now move on to the next question. Which of the following is false? Remember, false regarding Gaucher's disease. Crumpled tissue paper, yes, it is true. Characteristic. Beta glucocerebrosidase enzyme deficiency, yes, again, this is true. Ceramidase deficiency, no, this is not there. Where do you see this deficiency? You see it in Farber's disease, right? This is seen in Farber's disease. And bone pain, of course, it is seen in Gaucher's disease. So this is also true. So the incorrect statement or the false statement is option C, right? Okay, let's move on to the next question. Now, which of the following features are characteristic of Hirschsprung's disease? Hirschsprung's disease, there is failure of migration of ganglions. Yes, this is true. Non-cooperative peristalsis, again, this is true. Causes intestinal obstruction postnatally. Yes, it does cause intestinal obstruction. Now, distal segment is dilated. No, this is false. Why? See, if this is your intestinal segment and these are your ganglions. What happened in Hirschsprung's disease? There is failure of migration of ganglion. So there is proximal dilatation. Okay, now there is obstruction here, agar, so there would be proximal dilatation and distal constriction. Okay, proximal dilatation and distal constriction. So ये दोनों statements would be false. Only the 1, 2 and 3 options would be right. So this is the correct answer. All right. Now, moving on to the next question. Which of the following statements about rheumatic fever is false? Again, note, they've asked you about the incorrect statement. 2 weeks post sore throat, yes, it is true. Ashkoff body is seen, again true. Infection caused by group A beta hemolytic streptococci, again true. Myocarditis but not endocarditis, no, this statement is false. Why? We do not see only myocarditis. We can see myocarditis in some patients, but not only myocarditis. In fact, we can see pancarditis, right? So D is the incorrect statement and the correct answer. All right, let's move on to the next question. Okay, a boy presents with developmental delay, obesity, hypotonia, normal neurological development, and hypogonadism. His karyotype shows 45XY with deletion of chromosome 15, right? Chromosome 15. What is the most likely diagnosis? Once you see chromosome 15, it has to be either Prader-Willi or Engelmann. कौन सा होगा? Now, just see the features. Developmental delay, very important, obesity, hypotonia, and normal neurological development. So this is the case of, yes, Prader-Willi syndrome. So this is a case of Prader-Willi syndrome. Engelmann में क्या होता है? You see an abnormal laughter. What do you call these patients? Happy puppet. Happy puppets, right? And also remember, 15 deletion, chromosome 15 का deletion होता है, but अगर paternal gene deletion होता है, तो then it is Prader-Willi, and maternal it is Engelmann. So our case, it is normal neurological development, obesity, hypotonia, hypogonadism. So it is, the answer is Prader-Willi syndrome, right? So let's move on to the next question. So all the people staying in Delhi, I'm sure you will know the answer. Even if you're not staying in Delhi, you have to know the answer. Particles of size 2.5 will settle, micron will settle down in? Yes, will settle down in alveoli. Nose में particle size would be more than 10 micron. Trachea and bronchi, their size would be 5 to 10 micron. And alveoli, it is 1 to 5 micron. This particle size will definitely fall in your alveoli, right? So, coming on to the next question. Which of the following is true about the given condition? Now, I'm not sure if this picture was exactly given the way we have tried to simulate it, but I have heard some students also mentioning that there was mention of loss of retiridges in the question, thinning of the epidermis, and most probably it is a case of HPV infection. Okay, most probably it's a case of HPV infection. So let's see what are the true options given for HPV. Oncogenic virus, yes, true. Painful lesions, no. HPV produces painless warts. Okay, painless warts. Is it an RNA virus? No, it's a DNA virus. No vaccine available? Incorrect. There is vaccine available for HPV infection. I guess 3 questions were there from criteria. Jones criteria, rheumatic fever ka, and this one. So the option 2 and 4. Yes, this is option 2 and 4 is the correct answer. Let's move on to the next question. Okay, which of the following statements are correct about retinoblastoma? Now they've asked us about the correct statement. It is always unilateral. No, this is false. It could be bilateral in hereditary cases. It is associated with increased risk of osteosarcoma. Yes, it is a true statement. The RB protein is inactive or hypophosphorylated? No, the RB protein, there is a loss of function and mutation. The oncogenesis occurs by loss of function mutation, not because the protein is hypophosphorylated. So this is false, but the next oncogenesis occurs by loss of function mutation is true, right? The gene involved is called the guardian of the genome. No, the guardian of the genome कौन सा gene होता है? That is P53. But यहाँ पे involved is your RB gene, and that is what do you call the RB gene? The governor of the cell cycle. Okay, governor of cell cycle. So यहाँ पे हमारी true statement is B and D. Okay, B and D. That is your option A. All right. So retinoblastoma can be bilateral. It is definitely associated with osteosarcoma. Oncogenesis occur by loss of function mutation of the RB gene, and the RB gene or the governor of cell cycle is involved, not the P53, right? Let's move on to the next question. Okay, which is the most likely causative agent of the condition shown in the image? What is this image? Okay, this is a strawberry cervix. Strawberry cervix. And the causative agent is, yes, it is Trichomonas vaginalis. Very straightforward. If you can identify it's a strawberry cervix, to Trichomonas vaginalis comes the direct answer. All right. Now, moving on to the next question. Okay, again, a case of microcytic hypochromic anemia. I'm not sure how many of these questions were correct or exactly phrased, but we are looking forward to your suggestions, your feedback on what exactly was asked. Okay, a patient with microcytic hypochromic anemia, elevated RBC count and target cells on peripheral smear is suspected of having a hemoglobinopathy. So RBC count elevated hai, target cell hai, hemoglobinopathy kaun si hogi? Most probably it would be a thalassemia and most probably a beta thal minor. Which test would be the most appropriate to confirm the diagnosis? Again, a straightforward question. It would be hemoglobin electrophoresis. Serum iron or TIBC आप तब कहोगे जब they are not telling you of a suspected diagnosis of hemoglobinopathy. Then serum iron and TIBC would be your first investigation. But of course, confirming the diagnosis and when they are telling you it is a hemoglobinopathy, you have to do a hemoglobin electrophoresis, right? Okay, target cells. What is the another name for target cells? We all know it is podocytes. And where do you see target cells? What is the mnemonic that we have studied for target cells? Hot lips. Okay, hot lips. It is your hemoglobinopathy, obstructive jaundice, thalassemia, liver disorders, iron deficiency anemia. You also see it in post-splenectomy and sickle cell anemia, right? Target cell. How will it appear? As a dark condensed area, a target, bullseye. That is what is a target cell. And why is it? It is because of the altered membrane surface area ratio to hemoglobin content. Your hemoglobin content reduces and the surface area increases. That is the mechanism for formation of target cell, right? So with this, we come to the end of the session. We definitely await your suggestions, your feedback on exactly what question was asked, maybe the way questions were asked, the questions were framed, and any questions if we have missed out. Thank you so much and all the best for your results. Bye-bye.